have a ground round very rich and full of topics. Today is a woman in rhinology section of the American Rhinological Society dedicated on fungal rhinosinusitis. I'm very glad for their participation. We are going to have different topic with different speaker. So let me welcome everyone from Jivianne Lee to Patricia Loftus to Elina Toskala to Stephanie Shintani-Smith to Lauren Roland to Sarah Wise and to Amber Luong. Welcome everyone.
Thank you so much, Puya.
So today the topic is going to be focused on fungal rhinosinusitis, and as previously mentioned, we are going to talk about different aspects. So every speaker, she in this topic going to talk about one topic specifically. I cannot anticipate this because I want them to present their own. But in the meantime, I would remind to all the attendees, if you have any questions, you can type it from YouTube, from Twitch, from LinkedIn, from Facebook, and we will reply at the end of the presentation. So let's introduce the woman in rhinology. I give the torch to Jivianne. She is going to announce what's about the woman in rhinology.
I'm just going to go ahead and share my screen. Can everyone see that? Okay, great. Well, thank you so much, Puya, for inviting the Women in Rhinology section of the American Allergic Society to be a part of your international Grand Rounds. We're really honored to be a part of it. My name is Jivianne Lee. I'm the inaugural chair of the WIR. Just want to give you a little bit of a history of our Women in Rhinology section. Back in 2014, it really started out as this grassroots movement that was spearheaded by Dr. Amber Luong, who's one of the panelists today. The goal was to try to support career development and opportunities for women in rhinology. So then over the next couple of years, we had informal regular events and programs that were held as part of our ARS meetings and conferences. And then from 2017 to 2018, Dr. Sarah Wise, who's also one of the panelists today and vice president of the ARS, and Aaron O'Brien, they drafted the charter for women in rhinology. And then in October of 2018, we got official approval from the ARS Board of Directors to establish the very first women in rhinology section of the ARS. And we had elections for an inaugural Women in Rhinology Governing Council. So this was our inaugural WIR GC. We just had new elections a month ago. I was the inaugural chair. Dr. Toskala, who's also one of the panelists today, was a chair-elect. She's now the new chair of the WIR. Dr. Loftus, who's going to be moderating the panel today, is our information officer. Dr. Stephanie Joe is our financial officer. Doctors Lauren Look and Danielle Warner are members at large. Dr. Stephanie Shintani-Smith is our research chair. And then Dr. Karen Bednarski was our mentorship chair. And then, like I said, literally just a few weeks ago, we elected a new governing council, is essentially the same members, except now we have Dr. Stacy Gray, who's going to be the new chair-elect. Dr. Raymond Campbell is going to be our mentorship chair. And then Dr. Elizabeth Ferentz is going to be the new member at large.
Jivianne, I think your slides are not advancing. Would you be able to open up the presentation a little further?
It's not, you're not seeing the slides at all?
We just seen the first slide, which is the title. Yes.
That's really strange. Okay, let me try again. You want me to stop sharing and then?
Let's try. I think it's better.
Okay, let's see. Okay, let's try this.
Yeah, I think it's better now.
Is it advancing now?
Yes.
Oh, sorry about that. Well, I did go over all of this, so hopefully this is a nice outline to review it also. Sorry I did in advance. That's our history. And then this is our inaugural council, which I had just mentioned to you. And then the new additions to our GC. And then in terms of our mission statement, for the ARS, it's always been to promote excellence in the care of patients with disorders of the nose, sinuses, and skull base through research, education, and advocacy. So for the WIR, mission statement was to support inclusion and integration of women rhinologists to try to fulfill this mission on a global and international scale. So in terms of some of our WIR initiatives, our goal really was to try to establish a forum for communication and collaboration among women in rhinology. From a research perspective, we wanted to establish a database to promote communal collaboration and try to get funding for grants that would involve women in rhinology. We also were focused on establishing mentorship through various programs and modules. And of course, the overall goal was to try to promote career development for women in rhinology. Here's our Twitter and Instagram handle. And then finally, I also wanted to invite everyone to our ARS Virtual Summer Sinus Symposium, which will be held on November the 14th and 15th of this year. All right, thank you.
Great, so I would like to pass the torch to Patricia Loftus. She's going to moderate the session. I would love to remind once again to all attendees, I'm seeing your question. We will go through all the reply at the end. So I give the torch to Patricia Loftus. She's going to be moderating this session, and then she will proceed with every participant. Thank you.
Great. My slides, you can see everyone?
Yes.
Great. All right, so good evening, everyone that's joining us. My name is Patricia Loftus. I'm an assistant professor in the Department of Otolaryngology at UCSF. So I'm joining you from San Francisco, California, where it's currently 8 a.m. And I'd like to say good morning to all my esteemed panel members who are also on Eastern and Western Standard Time. So, we're so excited and we're so honored to have been invited to give this panel. All female panels can tend to be about certain topics such as work-life balance. And it turns out we actually know an impressive amount about fungal sinusitis too. So thank you for giving us a platform to demonstrate that. So I'd like to quickly introduce our panel members who will each give an approximately 7-minute presentation about their topic, beginning with Dr. Toskala, who is a professor at Thomas Jefferson University in Philadelphia. She will be discussing fungal ball. Followed by Dr. Stephanie Shintani-Smith, who is an assistant professor at Northwestern University in Chicago, and will discuss acute invasive fungal sinusitis. Dr. Lauren Roland is my colleague at UCSF, and she'll educate us about chronic invasive fungal sinusitis. Dr. Sarah Wise is a professor at Emory University in Atlanta, Georgia. She'll be discussing allergic fungal sinusitis, a topic that she is certainly an expert on since this entity is very prevalent where she practices. And then last, but certainly not least, we have Dr. Amber Luong. She's professor and vice chair of research at McGovern Medical School in Houston, Texas, and she will teach us about saprophytic fungal colonization. At the end of the presentations, Dr. Dehgani will lead an approximately 15-minute Q&A to answer audience questions that he collected during the presentation. So please feel free to send in any questions you have. Hopefully we have time for all of them. If not, we will provide our email addresses at the end, and please feel free to reach out to us with any other questions. And here is a list of the panelist disclosures. With that, I would like to turn it over to our first presenter, Dr. Elina Toskala, who will be discussing fungal balls. So I'm going to unshare my screen, and Elina, feel free to share yours.
Thank you, Patricia. Can you see this? Great.
Yes.
So good morning, afternoon, evening, wherever you are in the world. Thank you again for the invitation and Puya organizing this amazing educational series. I've been following you on Facebook. In addition to doing your push-ups, you do a lot. So it's been fun to follow your challenge that you're challenging some of our colleagues on that as well. But my background is from Finland, so I was supposed to know the time that 5 p.m. doesn't mean US, it could be actually elsewhere in the world. So that's why I'm from the OR, and I'm sorry about that. But anyways, my topic was talk about fungal ball and mycetoma. And my background is that I'm a rhinologist and also allergies, and many Europeans know that in Europe, allergy is often a subspecialty of ENT, unlike in US, where allergy is actually a main specialty. And so when you often see people talking, they, depending from their background, whether you're an ENT allergist or allergist as a main specialty here in US, have a little bit of different background. But my experience in Finland in fungal sinusitis is actually very limited because this is partly climate dependent. I saw some data from our own studies about 10 years ago in Finland, where we looked in the environmental effect of just fungal existing in the nose. And we know that fungal sinusitis can be very serious. We have several levels, and I'll show you the classification of this just before I go to the specific of fungal ball. And we do know that fungi emerge as a human pathogens, possibly because wider use of spectrum of antibiotics. We have much more patients in immunosuppressive treatments for transplant and autoimmune diseases. We have much more cancer chemotherapy, increased incidence of immune deficiency diseases. And we also have a lot of now biologics that can affect our immunity, and that's potential risk for having fungal disease. I've seen the most severe ones that I have treated here in the US from our cancer center with a lot of treatments and very poor immunity to defend anything that comes from outside, and also increased use of intensive care unit interventions. Fungal sinusitis is a manifestation of the fungi, and it's more important how it presents and what kind of a patient than what the organism is. We have the list of the most common organisms, but it's often the host's immune response that defines whether this is going to be there's nothing, there is a little bit something, or there is a severe disease. Infiltrating disease may occur in immunocompetent patients, as I said before. You can have fungal forms in a superficial epithelium without having any disease. We divide the fungal sinusitis non-invasive and invasive, and non-invasive are the allergic fungal sinusitis, and then the sinus mycetoma that I'm going to talk today. And then we obviously have the other topics covered today as well. Invasive forms of granulomatous invasive fungal sinusitis, acute fulminant invasive, and then chronic invasive fungal sinusitis. The invasive is obviously much more severe than me talking about fungus ball, and even less the saprophytic growth. The fungal-related eosinophilic rhinosinusitis is something that's been debated a lot, and whether the fungus plays a role in CRS, I don't think we have definitive answers, but it's been shown that treating fungus in CRS doesn't change the outcomes. So the role of fungus, unless there is a fungal disease as in just a saprophyte and causing immune response, is probably not very significant. If you remember, the older of the colleagues remember 10, 15 years ago, there was huge debate about this. And then we end up realizing that it's not a thing that explains all the chronic sinusitis, the fungus from the environment. So sinus mycetoma, the most common form of the fungal sinusitis, mainly in maxillary sinus. We don't really know why patients get this. It's most of the time unilateral. There's not really a point of infection. A lot of patients have nasal polyposis and hypertrophic sinusitis, but not always. Sometimes it's just an incidental finding and hasn't really caused much of symptoms to patients. Can be asymptomatic or symptomatic. It's a colonization of sinonasal mucosa with a benign fungal hyphae, and it's often responds to the changes in sinonasal microenvironment, whether there's been a surgery that exposed the sinus more into the environmental air and also fungus. When we open the maxillary antrostomy made it large, we obviously expose the sinuses also to the environmental, different kind of environment that can then also get contaminated with inhaled, for example, fungus or other bacteria. We have actinomycetes or actinomycetomas or true fungal sinonasal masses, most common in tropic, but it also seen in cooler climates, and especially when patient has an immune compromised state. In general, when you look at the species, most common in fungal ball is Aspergillus. You can see here a picture of Aspergillus fumigatus. You can have some of the other ones, Alternaria, Curvalaria, and maybe Fusarium as well. In the invasive forms, we mainly have Aspergillus and mucormycosis, and I'm sure that's going to be covered in next talks. So diagnosis, it would be ideal to get a fungal staining, but we all know that it is tedious. There's also a risk of contamination. There's a risk of false positive. It takes up to 2 weeks to get a final result. You often get a preliminary read if they see hyphae there, and then they can tell that there's suspicion of that, but to get the really culture takes a long time. But it is the gold standard for the diagnosis of fungal sinusitis. The problem also is that most people have some fungus in the nose, and when we, in our study 15 years ago, used PCR, you find it in a lot of patients, and that's not the solution of trying to be more specific, because we don't know which one is just saprophytic and which was actually causing disease. So most of the time we end up using imaging to do a diagnosis, and in CT you can see focal mass or diffuse area of hyperdensity here, hyperdensity here, and in the MRI you have decreased intensity, both T1 and T2, and intralesional calcification, and often reactive osteitis, so that the sinus bone gets thickened when the fungus has been sitting there a while. Surgery is the treatment of choice. Most cases you can do endoscopically through the antrostomy, and we have to treat the underlying infection. If there is an infection, often the fungal ball can obstruct the ostium and you develop reactive hypersecretion there and chronic sinusitis. And then there can be fungus elsewhere. So it's always good to check the whole cavity, and obviously your imaging will show you where the problem is. Saprophytic fungus, just a quick review on that. We see it often in CRS, but it's also normal in patients without the disease. This is a study about 10 years ago, 15 years ago, I think, 233 healthy subjects. And when you do nasal sinus rinses, whether you had chronic sinusitis, you had 91% positive. This was PCR. Whether you had a sinus surgery, you were 90%, or you were controlled, 90% had some fungus in the saline rinses checked by PCR. And we did, like I said, in Finland, a study just to look how the environment affects. As you know, in Finland, January is pretty damn cold. So no fungus is going to live in the environment. And we were able to see that in January, nobody had any fungi in their lavages. But in September, 50% of the controls and 21% of the CRS patient had fungi there. And when you look at the aerobiologic unit, they were showing same Alternaria and Cladosporium in the air. So we definitely have it in the nose. So that was my short presentation and introduction to the topic. Thank you.
Thank you, Elina. That was great. Next up, we have Dr. Stephanie Shintani-Smith, and she's going to go ahead and share her slides. And again, she'll be discussing acute invasive fungal sinusitis.
Well, greetings, everyone, and thank you so much for having me today. Can I get confirmation that you can see my slides in presenter view?
Let's see, we see your slides and can see the slides on the side. It's not fully open. Yeah, there we go.
Great. All right, so I will be presenting today on acute invasive fungal rhinosinusitis, and that is synonymous with acute fulminant and necrotic fungal sinusitis. So also I'll be referring it to as an acronym AIFS. And this is, as you know, a very rare but aggressive and oftentimes fatal disease. It's defined by the presence of fungal hyphae within the sinonasal mucosa and surrounding structures that occurs in the setting of sinusitis symptoms lasting less than 1 month. However, we do know that fungal invasion with its subsequent thrombosis and progressive tissue necrosis can actually occur over a matter of hours, very quickly. And unfortunately, there have not been really very many major changes in outcomes over the past 20 years. The fungal organisms responsible for this vary by global geography. However, the most common are Rhizopus, Mucor, and Aspergillus. So these fungal spores are everywhere. They're ubiquitous. They're in our soil, our plants. Here's a very adorable looking strawberry that's actually covered in mucor. And actually these inhaled fungi form part of the normal sinonasal flora, as Elina mentioned. Typically, fungi are unable to penetrate the normal epithelium, however, and our innate and adaptive immune responses control them. Immune dysfunction, however, can alter that protective mucosal barrier. And we don't really understand the immune response and cytokine profile of AIFS. There's very little known about it, but it does appear to involve a very scant but variable inflammatory cell reaction. Invasive fungal diseases overall, this includes pulmonary infections and other various body sites. These infectious invasive fungal diseases are actually increasing emerging problems worldwide. This is thought to be driven by the increasing use of immune modifying drugs, as well as increasing prevalence of diabetes and an overall aging population. Epidemiologic data is overall scarce, but I did find a couple of studies, one that showed 27 invasive fungal disease types of any sorts per 100,000 patients in an overall large US healthcare network. And a study of hospitalized patients with hematological diseases in Taiwan had an incidence of 2 acute invasive fungal sinus cases per 1,000 of these patients. The clinical presentation, as you most likely are aware, involves an immunocompromised patient, although sometimes this can affect immunocompetent people. They will have variable symptoms of sinusitis. They may have one symptom or multiple, the most common being, of course, facial pain, facial swelling, nasal obstruction, and fever. Moving on to diagnosis. Nasal endoscopy is paramount. And also, this is a theme. We find a lot of variations in how we encounter our patients. But early on, the changes may be very subtle and can fool you. There may just be some subtle edema in the nose, in the nasal cavity, or in the middle meatus. Later on, it's not until late in the game that we see the onset of pale or dusky mucosa, the crusting or ulceration, and then the numbness of the mucosa. But keep in mind that that can be a late finding. Whenever you have a clinical suspicion, we proceed with biopsy and hopefully a frozen section analysis. Frozen section analysis is a sensitive and specific method for timely diagnosis, but it is only 85% sensitive. So I suggest, to our teams, our trainees, we go to the operating room if a clinical suspicion is high enough and proceed with operative biopsies. In terms of imaging, there's again, no sufficiently specific finding. There's no pathognomonic finding. The variable findings can range from very subtle mucosal thickening that's typically hypoattenuating. And there can be bone destruction, but it's not always there. And then as the disease progresses, you'll see fat stranding in the infraorbital fat, periantral fat, masticator space, and the pterygopalatine fossa. So this is an example of a case that fooled me early on. This is a 40-year-old patient awaiting a liver transplant. He was encephalopathic and just one day was found to have a dilated fixed pupil and a fixed globe. His MRI was performed to rule out a stroke and didn't show any sinonasal disease at all. And this is a CT scan. In the scan, we only see a little bit of perhaps mucosal thickening here on the sphenoid base and probably just some dependent fluid here from the Dopov tube. We did an initial endoscopy, which just showed some dry mucosa, but it wasn't impressive. 12 hours later, we went to the operating room and encountered mucor. So I just use this as an example of a CT scan that shows very minimal findings, but the clinical suspicion led us to the OR. MRI can be useful to improve diagnostic accuracy if you've got time for it, and is really helpful to assess extent of spread to the eye and to the brain. Again, variable findings on MRI. Lack of contrast enhancement is something that we talk about a lot. This can be seen in about 50% of cases, and it's thought to kind of relate to the overall fungal hyphae burden and coagulative necrosis. You will see either heterogeneous or homogeneous enhancement in the other 50%. So again, variable findings here. I could spend a whole hour lecturing about imaging findings, but we'll move on for time's sake. In terms of laboratory testing, there really isn't a go-to here. We still rely on tissue diagnosis. There are immunological and molecular methods that are potentially kind of on the horizon, mostly for other invasive fungal diseases, specifically invasive pulmonary aspergillosis, where ELISA tests can be helpful, PCR can be useful, and now point of care, very fast lateral flow devices are used on bronchoalveolar lavage. But again, there's nothing here for acute invasive fungal sinusitis. And similar to what Elina said, cultures really are not reliable or timely. And in one study, or in a couple of studies, the rate of positive fungal culture, even for a known fungal ball, is quite low at about 30%. For treatment, this disease really requires a multidisciplinary approach. The most significant positive predictors of survival are surgical debridement and antifungal therapy. Endoscopic sinus surgery with or without extended endoscopic sinus approaches, such as an endoscopic maxillectomy, Denker's approach, Caldwell-Luck transmaxillary approach, or a draft 3, are typically sufficient for at least the initial surgical approach. The overall guiding principle is that you debride all the necrotic sinonasal tissue until you get a freely bleeding edge, and or until you get a negative intraoperative frozen section. The intraoperative frozen sections have a 70% negative predictive value. So that can be confirmatory if you think you're done. And then typically I'll repeat a surgical debridement the next day or 2 days later, and thereafter as needed if the disease shows any progression. Now, when invasive fungus is found to spread beyond the sinuses to the orbit or intracranial cavity, we really need to consider risks or benefits of potentially disfiguring or morbid operations, including rhinectomy, maxillectomy, craniotomy, and orbital exoneration. And these cases are considered on a case-by-case basis. Justin Turner in 2013 did the largest systematic review to date, and did not find that these procedures offer much of a survival benefit. However, these procedures really are only done in advanced disease, and so these patients likely have a poor prognosis regardless. So it's hard to say. And so again, a case-by-case decision for these cases. When I was training, we were taught that essentially orbital exoneration, removing the eye, was indicated for orbital invasive fungus. However, there are a couple of recent, very limited small case series suggesting that vision sparing modalities may confer similar outcomes or better outcomes because they're vision sparing. The conservative orbital debridement can be undertaken, and then there are a couple papers looking at a single injection of transcutaneous retrobulbar injection of amphotericin. In terms of antifungal therapy, you start empiric, perioperative, preoperative antifungal therapy as soon as this disease is suspected. We typically then treat with amphotericin B for mucor. The liposomal form of amphotericin B is new and less nephrotoxic. However, it is much more costly and typically 10 to 50 times more expensive, but worthwhile in a lot of cases. Voriconazole and posaconazole are used for aspergillus, and a newer drug, isovuconazole, was recently approved, at least here in the United States, and has potential to treat both aspergillus and mucor. Again, as I said, in terms of outcomes, there have been no major changes or progress in 20 years. However, there are a lot of discrepancies between single studies of published reports of what are the positive prognostic factors and what are the negative prognostic factors. And over survival rates range. I've seen anywhere from 10 to 90%. But Justin Turner published that largest systematic review. There were 52 studies, all case series or single expert presentations. But there were 807 patients in this study. The overall average survival rate was 50%. Improved survival was noted in diabetic patients, those who received liposomal amphotericin B, or those who underwent surgery. What's the future of AFS? As a scientist and clinician, I'm hopeful that we'll find improved diagnostic tests, better antifungal therapies, clarification on how to manage the orbit, and further insights into epidemiology and pathogenesis. And I'm very interested in this topic. I welcome any emails for comments, discussion, or questions.
Thanks, Dr. Smith. Let's move right along so we can try to get to some questions. So Dr. Lauren Roland will be up next and discussing chronic invasive fungal sinusitis.
Great, thank you. Can you see my slides?
Yes,
okay.
We can.
Chronic invasive fungal sinusitis is the most interesting form of fungal sinusitis because there's just so much that we don't know about it. So lots to learn. And this is the current classification, as you've seen, with invasive split into acute and chronic based on timeline and aggressiveness. And chronic has two subtypes, granulomatous and non-granulomatous, which are defined by the pathology. So we define chronic invasive fungal as a slower course than acute. Generally, we say 12 weeks of symptoms. And there needs to be fungal invasion of mucosa or bone. You do not need angioinvasion as we often look for in acute invasive fungal. And clinical features are a lot more subtle than acute cases. So this can make it challenging to diagnose. Patients will complain of nasal congestion, vision change, pain, whether that's facial pain or orbital pain. But a lot of times patients won't necessarily have a lot of sinus symptoms, but they'll have more eye symptoms or maybe very few symptoms at all. Imaging findings are variable, and that can also make the diagnosis challenging. But if you ever see bony erosion on CT, that should be concerning. MRI can show hypointense signal, and if there's ever enhancement or extension into, of course, intracranially or into the orbit or apex, that should raise suspicion, even if there's not a lot of sinus disease. Treatment includes OR for diagnosis, so it's a little different than acute cases where you really want to remove every last piece that you can see. Because this tissue might not actually look all that necrotic, and it might be difficult to tell what is normal tissue and what's abnormal tissue. So you should use your image guidance to help you get to the right spot for getting a biopsy. And after a biopsy that confirms a diagnosis, IV antifungals are usually used and then transitioned into long-term oral antifungals. And I have seen patients who several months after treatment forgot to take their oral antifungals, and chronic invasive fungal can and will come back. So I would recommend including infectious disease in treatment so that those physicians can help you manage antifungals and any side effects. Granulomatous chronic invasive fungal usually has a better prognosis than non-granulomatous and affects healthier patients, even those who are completely immune competent. And it's defined by the pathology of granulomas and multinucleated cells, and is more common in certain parts of the US and then certain parts of the world. So there's likely some kind of climate or humidity or environmental component to this. What we don't know is why only some immunocompromised patients develop this. So it's very rare, and patients really aren't all that immune compromised sometimes. They may be on oral steroids or some kind of immune modulator. And there are also immune competent patients that develop chronic invasive fungal. And so why that is, we don't know. It also seems anecdotally that the eye and vision seem to be at risk, but we're not quite sure why those areas are commonly progresses to those areas. So I'm going to present two cases that are very different, that are both chronic invasive fungal that I thought are interesting to help us just always be thinking about this as a possible diagnosis. So the first is a patient with eye pain, a normal immune system, but many years of eye pain. And if you watch the right side, the right eye, you can see that there's some soft tissue abnormalities there, but not a lot of sinus disease. So interestingly, here is some surgical video. You can see there's no necrotic dead tissue like you'd expect in acute invasive fungal. Everything is bleeding and it looks pretty normal, but there's a sort of pale abnormal mucosa. It's not necrotic or dead, but it is a little bit abnormal looking. And that was located at both orbits. And this came back as chronic granulomatous IFS, and you can see the multinucleated cells there. The second patient had a history of cancer, but was completely recovered, normal neutrophil count, not severely immune compromised like you'd expect in an invasive fungal case, but had progressive vision loss over a month or two that led to blindness. And again, the right eye, if you watch, you'll see the sinuses are very clear, but there's some bony dehiscence on that right side in the sphenoid back by the optic nerve. And then in that same sphenoid, but not immediately adjacent, a little bit of inflammation. Here's the bony dehiscent area again. And interestingly, that sort of abnormal ring of tissue there came back as chronic invasive fungal sinusitis, but non-granulomatous type. And the inflammation was a fungal ball. And if this is a coincidence or progression of disease, we don't know, but sort of interesting. There have been some reports of conversion from non-invasive fungal disease to invasive fungal disease. This is a case report of a patient with allergic fungal sinusitis that progressed to chronic invasive fungal sinusitis. And then this is a small case series of patients with fungal balls adjacent to microinvasion of mucosa. And so again, are these coincidences or is there true progression of disease? When I previously worked at Emory, we reviewed our chronic invasive fungal patients, identified a handful of patients with symptoms greater than 1 month, so outside of the acute time frame, but with more aggressive disease than typical chronic invasive fungal. And 90% had orbital involvement, 40% had a fungal ball. This is a picture of a fungal ball on CT, but 40% had a fungal ball in the same sinus at the time of surgery, documented. So this is interesting and sort of raises questions about how we should really be defining chronic invasive fungal and if it can progress from non-invasive disease. So it makes me wonder if fungal sinusitis should be defined as a spectrum from non-invasive disease to acute invasive fungal sinusitis, or if there's truly progression. And if so, we should be working to identify who those patients are and why it's happening. So in summary, if you suspect this disease, you'll want to go to the OR if your patient is stable for biopsy. You do not need to surgically remove every little last bit, but you do need a biopsy with enough tissue to give yourself a diagnosis. Continue long-term oral antifungals after doing IV antifungals initially, and I would recommend including infectious disease to help you with that and help you with duration because it can be challenging. And please always consider invasive disease. So if you have a biopsy with non-invasive disease, but then things are not looking right for your patient, symptoms are confusing or things seem to be progressing, always consider the possibility of invasive disease. And that's it. Thank you.
Great. Thank you, Dr. Roland. Next up, we are going to have Dr. Sarah Wise present allergic fungal sinusitis.
All right. Hopefully everyone can hear me. Give me 1 second. I'm working on some screen sharing here. I want to take a minute to just thank Puya and the NasoSano organization for the invitation to speak and share a little bit about allergic fungal sinusitis with you all. I hope that my slides are coming through.
They're working, yep.
All right. So I'm at Emory University in Atlanta, which is, as Patricia said, a little bit of a hotbed for allergic fungal sinusitis. So I'm going to share a little bit of that experience with you. And I'll start with the presentation of a case. So this is a 26-year-old woman who came in with nasal obstruction. Really, main complaint is congestion, and it's been persistent for at least 6 months. There are some seasonal symptoms that are associated with allergy, like sneezing and rhinorrhea, and those worsened since moving to the area about 5 years before. The patient also reports some mucoid discharge that's described as gooey and thick, as well as hyposmia, but there's really no pain or headache or anything like that. There is, however, an allergy history, and the patient had reactive airway disease as a child. So if we look at this patient's scan on the left and the endoscopy on the right, you can see that there's going to be significant left-sided sinus disease with significant opacification, as well as some heterogeneous densities within the sinus cavities. And that it is most prominent in the maxillary sinus, and then also as we get back to the sphenoid sinus as well. You can see as well that there's some expansion of the sphenoid intersinus septum over to the right, noting some sort of erosion and expansion of the bone. So after failure of medical therapy, which typically includes oral steroids as well as topical nasal steroids, this patient ends up going to surgery, and we can see in our endoscopic surgical video significant polyposis and inflammation, as well as this very, very thick allergic and eosinophilic mucin. And this can be incredibly rewarding to operate on, very fun to remove from the sinuses, but also very challenging. Over on the right side of the screen, you can see some pathology slides noting significant eosinophilia within the mucin, as well as non-invasive fungal hyphae. So in this case, our clues really are an obstructive phenomenon in the nose. Hyposmia is often present. A lot of these patients do not present with any pain or pressure in the sinuses, and this very, very thick mucus discharge. This is going to be most common in sort of temperate climates with potentially humid environments. And there's also often a history for some type of atopic disease. The most commonly quoted diagnostic criteria for AFS were published in 1994 by Bent and Kuhn. And you can see that there's a distinct allergic association with a type 1 IgE-mediated hypersensitivity. And then also the several of the other characteristics that I described, nasal polyposis, these CT scan findings of the heterogeneous densities, and often you'll see that bone erosion or expansion. And then the two pathologic criteria, which are eosinophilic mucin and a positive fungal stain. So I like to spend a little bit talking about really the surgical treatment of allergic fungal sinusitis, because that's a very important part of the initial treatment. So it's important in my view to really widely open the sinus ostia with surgery. You want to really create a wide opening so that number one, you can remove the mucin, and number two, that it doesn't get stuck there again later in the future. You can remove the polyps, and sometimes it will take quite a bit of work to get this mucin out. So suction, curette, irrigate. Sometimes you have to actually be very patient in getting the mucin out, but it's really important to do so because you don't want to leave any behind and allow the disease to recur quickly. I'll also talk a little bit about some of the sort of tips and tricks that we can do with our instrumentation. So we use a lot of angled scopes in these cases so that we can really look around corners, especially in places like the alveolar recess of the maxillary sinus, up in the lateral recess of the frontal and sphenoid sinuses as well, because that mucin really likes to hide in those cracks and crevices. And then we'll use a lot of angled instruments. Even instruments that are designed for frontal sinuses can be very helpful in some of the other sinuses. Things like this particular grasping forceps, which often we'll use just in the closed position to kind of dig mucin out of some of those recesses, like the maxillary alveolar recess. So our goals here to go from an endoscopy picture that looks like this with lots of mucin and polyps to widely open sinus cavities at surgery. And then ultimately when things are healed, we want to see these wide open spaces and prevent any trapping of mucus there in the future. So I don't think that AFRS is a disease that we should be treating with small hole surgery. And I've kind of said that over and over. And a lot of times this can just be treated with traditional endoscopic sinus surgery, but sometimes people advocate increased, more wide approaches. So things like maxillary megaantrostomy or modified medial maxillectomy to help reach into some of those recesses and allow improved monitoring and irrigation and follow-up. Also, things like draft 3 frontal sinus surgery or an endoscopic modified low throat procedure has been advocated for patients with certain characteristics like nasal polyposis, high Lund-Mackay score, or small frontal ostium size. Even with these extended approaches, sometimes AFRS will come back in the future. And in this particular series from the Adelaide group in Australia, AFRS was a significant risk factor for the need for revision for low throat procedures, although it was largely soft tissue disease that had to be cleared out later. When we look at the medical therapy for allergic fungal sinusitis, there's not a lot of great evidence for treatment of this disease, but it is important to help try and alleviate some of the inflammation that goes along with it. So short-term oral steroids in the preoperative and postoperative period, topical nasal steroids, as we see for the vast majority of other chronic rhinosinusitis with nasal polyposis diseases, and then oral antifungals can potentially be useful in refractory cases. Because this is an allergic phenomenon, a lot of people talk about immunotherapy, but I'm going to highlight that the data that we have for allergen immunotherapy is not particularly strong. And so in my patients, I consider this an option. I do talk to all of them about it, and some of them do very, very well with it, but I think we need a lot more data to have strong recommendations for this in the future. The last thing I'll mention is that there's a wide range of allergy prevalence depending on the particular subtype of CRS with polyps. But you'll see that AFRS, largely based on the diagnostic criteria of this entity, does seem to have a very high prevalence of allergy. It was 100% in our series of 356 patients. So with that, I will stop. I think that is my 7-minute time, and I'll turn it back over to Patricia. Thanks so much.
Thanks, Dr. Wise. That was great. And now we are going to end with Dr. Luong, who is going to speak to us about fungal colonization. When are fungal cultures indicated?
Good morning and afternoon, I guess from around the world. This is a great meeting, and I appreciate Dr. Dehgani for organizing this and inviting us to present. So what I'm going to do is sort of wrap up and highlight some of the things that were discussed and kind of focus a little bit more on the role of cultures. So the objective of the study of what I'm going to be talking about is to understand how this host immune response, which I think many of our speakers have already talked about, and how that relates to how fungus can interact and dictate the type of disease state that we see, and then talk a little bit about the role of fungal cultures in our practice. These are my disclosures. So I will say, though, that in my disclosure that I really do enjoy understanding how the role of fungus plays in our respiratory diseases. As you can already see, as highlighted by our various different speakers, that the disease type can vary significantly, but fungus is present ubiquitously around our environment. And why some people get afflicted with a fungal-driven sinusitis type of disease and why some people are not is very curious to me. So it's found in the environment, both indoors and outdoors. It's very ubiquitous. And what happens is that for most of us, the fungus in the environment is present in spores. And when the spores are able to, are a kind of a dehydrated state of the fungus. And when spores are able to rehydrate because of the presence of moisture in the air, then they can germinate into this fungal hyphae form that you and I have sort of interact with in terms of sinonasal disease. So just real briefly, this is the fungal life cycle, and it's important because you'll see how what we see in the sinuses and why we don't see, and why some of the cultures come out the way they do, is really kind of understanding this life cycle. So as I've mentioned, fungi typically are in this spore, dehydrated, very protected form. And this is the form that you see in the environment. And so, as I mentioned, if it finds an environment such as our sinuses, where it's warm with a lot of moisture, then you have this ability of the spores to rehydrate and then form into this hyphal form. Now, it's this hyphae form that is very immunogenic. So it has a lot of protease activity. It has chitin and beta glucans, along with other things that can incite a very strong immunogenic response. So as many of the speakers have already talked about, I think what's fascinating is that the presentation of what we can see, which we've already talked about several of them, how this disease state really results from this interaction of the fungi and the host immune response. So on the one end, you have the immunosuppressed state. So, and then this whole line that I've shown here goes from this immunosuppressed state to the immunocompetent, and then this hypersensitive state to fungi. And so just to put it onto this spectrum, the diseases that we've talked about today, it's really interesting how, number one, you get a nice spectrum of these diseases, but how it relates to the fact that the fungi are so ubiquitous, how it relates to how the host interacts with that fungi. So as Dr. Smith talked about the acute invasive fungal sinusitis, in basically 100% of those patients, there is a significant immunosuppression. And even with the antifungals, you are unable to really change the patient's prognosis without really dealing with the patient's immunosuppressive state. And then, which I agree with Dr. Roland, this chronic invasive fungal rhinosinusitis, where I put it here in this immunosuppressed state, but yes, there's this component where it's a local immunosuppression rather than a systemic immunosuppression that we may see with the acute invasive fungal sinusitis. And then fungus ball typically occurs in an immunocompetent state. And then allergic fungal rhinosinusitis, which Dr. Wise talked about, you have to have an atopic state to be, by definition, to have allergic fungal rhinosinusitis. And so I'm just going to briefly talk about saprophytic fungal colonization, because there's not really much to it, frankly. And it's basically the situation where you can have fungal hyphae or fungal growth on typically a non-living surface. So not on the mucosa, but it may be in the sinus case, it's on a crust. So you can see here, although this is not the best video, of one of my patients who's been on various different medicated saline irrigations, you can see this white growth here on the sinonasal cavity. And you can see the crust, or at least the hardening. So it's not the mucosa, but it's actually a thin crust that this fungus is growing on. And so the treatment is quite simple. You remove the crust and then continue with saline irrigation. But it's basically a colonization of fungus within the sinus cavity. So just for completeness sake, saprophytic colonization typically happens in an immunocompetent patient. So, you know, I wanted to switch over to cultures and where did the role of cultures play? And as you can see, and many of our speakers have talked about, cultures really don't play a role in terms of the diagnostic or even treatment. And that's the only reason why you would do a test, right? You want to know if the results help you with the diagnosis of the disease, or can help you with the treatment. And in the situation of invasive fungal sinusitis, it really is about whether you can see fungal hyphae invading into the tissue. And in that situation, cultures really doesn't play a role. And frankly, it's just takes too long to really help with the diagnosis. In terms of fungus ball and saprophytic colonization, that diagnosis is based on either imaging or nasal endoscopy, and doesn't have any, the cultures really play no role in terms of treatment, because you're not going to give them antifungals in this situation, and the surgery really deals with it. So in that situation, cultures play no role. Now, allergic fungal rhinosinusitis is quite interesting, because as Dr. Weiss mentioned, the most accepted criteria for allergic fungal rhinosinusitis, one of them is this presence of fungal organisms within the mucin, either confirmed by histology, culture, or both. And as many of you who have treated allergic fungal rhinosinusitis patients know, even sending in the mucin for pathology, oftentimes it's very difficult to see or identify fungal hyphae within this. And so therefore, you can see why cultures may play a role in helping to make this diagnosis. And Dr. Toskala also brought up a very good point in this confusion, and there's still a lot of debate about this, is whether or not allergic fungal is in of itself a separate entity from some other eosinophilic CRS with nasal polyps. And the only thing that differentiates allergic fungal at this point from maybe some of the eosinophilic chronic rhinosinusitis is this presence of being able to identify the fungal hyphae. But as you can see, this is a data that was presented by Dr. Panikow many years ago. Even in patients where you can see fungal hyphae on histology, fungal cultures are only positive in 60% of the time. So the fungal cultures at the time, once upon a time, were very insensitive, and so therefore didn't help in terms of the diagnosis or even in the treatment. So Dr. Panikow and group, and I think Dr. Toskala brought this up very well, fungi are ubiquitously found in the environment. And so you would expect that you should be able to see fungi more commonly in the sinonasal cavity. And so they developed a mechanism to actually reduce the mucus, so break down the mucus. And in doing so, what they did was they took patients and just had them do nasal lavages, frankly. And so they blew their nose, treated the mucus with a reducing agent, DDT. And what they found was that fungi could be cultured not only from about 97% of patients with chronic rhinosinusitis, but 100% of patients who are healthy controls. And it just basically reflects the fact that if you're going to blow your nose and then you make sure that you can get the spores to culture out on a plate, you can get fungi growing in your nose 100% of the time because of the environment having fungi present ubiquitously. So going back, oops, I don't know why there's missing darn it. Okay, so it's missing one of my slides here, but we did a study. Where we took patients to the operating room and took samples from the maxillary sinus and from both healthy controls as well as CRS with nasal polyps and allergic fungal rhinosinusitis patients. And what we found is that if you reduce it, basically opening up and breaking down the mucus, you can get 100% of fungi growing from allergic fungal. You get about 60% growth from CRS with nasal polyps, and you only get 20% from healthy controls and CRS without nasal polyps. So by taking the samples from the maxillary sinus or the various different sinuses directly, rather than having a patient blow out their nose, you can get a little bit better specificity and not lose too much of the sensitivity in terms of growth. And so in that situation, that might be able to help you in terms of allergic fungal. But frankly, the take-home message is that at this point, fungal cultures is not routinely used and needed for the diagnosis of fungal-derived rhinosinusitis, just because, number one, as you can see, it doesn't play a role in the treatment. for most of the cases, and in allergic fungal rhinosinusitis in terms of the diagnosis. And then in terms of the treatment, at this point, topical antifungals and oral antifungals don't seem to play a role at this point in managing of allergic fungal rhinosinusitis. So at this point, I would argue that fungal cultures are not routinely needed. So with that, I will end with these two take-home points, that the host immune status really dictates the susceptibility and expression of the various different types of fungal sinus disease that we can see. And there seems to be no routine role of fungal cultures for either the treatment or the diagnosis of most of the fungal rhinosinusitis diseases that we see. Thank you.
Thank you, Dr. Luong. Thank you to all the panel members. Those were great presentations, very informative. It has hit the end of the hour, so I know that some people have to run to clinic and OR, so if you need to, please feel free. But if anybody on the panel can stay around for a couple minutes, maybe Dr. Dehgani, if you wanted to ask a few questions, maybe we can stay on for another 5 to 10 minutes if that's okay with everybody.
Perfect. First of all, I would like to congratulate for the brilliant presentation and you actually being perfectly on time. It's like a miracle. It never happened before, and this is amazing for me. And let's go back to the questions from the audience. So the first one is there an association of maxillary fungal balls with previous dental treatment? If any one of yours would like to reply on this, you're free to respond to that.
I have seen that in the literature, also that fungal ball is less common in children, so it's as people age, and so there might be some association with time, that it takes time to develop. And since maxillary sinus is a very common place for fungal ball, yes, there's a thought that it can be associated with poor dentition or dental work.
Good. Second,
I would say that it's probably not it's not a one-to-one, right? So I don't think that odontogenic rhinosinusitis is often results into a fungal ball.
All right, so the second question is, which diagnostic criteria you would suggest instead of one described by Bent and Kuhn for allergic fungal rhinosinusitis?
So I see that Sarah had to step away, but so allergic fungal rhinosinusitis, it's one of those things, at least for initial presentation, it's when you see it, you know it, meaning that it's this whole constellation of criteria. So it typically presents in your younger patients with nasal polyps, right? So eosinophilic CRS with nasal polyps, typically other than allergic fungal rhinosinusitis, typically presents in, let's say, the 30s, 40s, and 50s, while allergic fungal rhinosinusitis more commonly presents in the 20s. So that, number one, already should make you think of allergic fungal. And then all the other criteria, polyps, the presence of eosinophilic mucin. So you'll see that on imaging, the CT scan that Sarah showed, where you get this hyperdensity within the sinus cavity. So that puts you into the realm of thinking about eosinophilic chronic rhinosinusitis. And then the age of the patient presenting makes you start leaning towards allergic fungal. And then the fact that you have to show atopic fungal specific type 1 hypersensitivity, whether it's through elevated fungal specific IgE or through a skin testing. So that criteria. And then finally, the fact that if they show up with unilateral disease, that by itself, and you've got all these other criteria, that's allergic fungal. So it's one of those things, it's like when you see it, you know it, but it's hard to put a criteria list around it.
Thanks, Amber. That was very good explanation. I have found it a little difficult. It wasn't, it's a very much came the diagnostic criteria from US. And I think also it has maybe some differences with the environment. I'm not sure if we really need to have the atopy proven if you have everything else, because that could be patient specific. Some patient might be easier getting sensitized than others. And I always wonder, how it doesn't make any difference. There's no studies showing that if you would do, let's say, immunotherapy, at least that I know, that would change the outcome of the study. So that's kind of confusing to me. Everything else, you have the polyps, you have the findings, you have the symptoms, you have your culture or your pathology showing fungus, but do we really need the allergic, the atopy there? I don't know what you're thinking.
So, oh, go ahead.
Oh, I was going to say that's a great point both of you guys have made, and the question. So we always present these criteria that are very old, but then we always say, but we don't quite know if maybe we should be changing them. And there has been some work that's looked at for patients that don't have elevated IgE levels or positive skin prick testing that actually have localized sinonasal IgE or eosinophils. And so it might be that this is, sort of an area of research that we can do. But I think currently, since we define things so strictly for our research looking at AFRS, we might have too small of a group that we're looking at.
So I think it's an interesting topic for sure. I would love to be able to look at maybe an international version of what people are defining as allergic fungal, because at least in Texas, and it's my own bias, when I'm in Texas, I see a very dramatic, very clear definition of allergic fungal rhinosinusitis, and I see everything else as presenting very differently. But I think you bring up a great point, Elina, in the fact that maybe we need to look at what people are defining as allergic fungal in, let's say, Finland, right, or in Europe, and then what we're defining in the South, and maybe even what's happening up in North US, what they're defining as allergic fungal, and let's see if we can find some clear differences based on microarrays, RNA-seq differences, and see if expression patterns are different and endotyping are different, and that will really tell you the difference.
Mm-hmm.
So I think that we have time for other two, if you don't mind. Other two questions. The first one is there any relationship between allergic fungal rhinosinusitis and allergic bronchopulmonary aspergillosis in regards to type 3 hypersensitivity reactions to fungal antigens?
Do you want me to take that, or Lauren or Patricia?
Amber.
So as you can tell, I love allergic fungal rhinosinusitis, and I've spent my last 15, 17 years just researching it. So allergic fungal rhinosinusitis initially was linked to ABPA because of this hypersensitivity, but there is some clear differences. And so other than sharing this hypersensitivity relationship, there's so many differences, and there's not this concurrence, right? So allergic fungal rhinosinusitis patients do not present with also ABPA. So in fact, AFRS patients have a significantly less prevalence of asthma than CRS with nasal polyps. So the prevalence of asthma in AFS patients is only 20%, while in CRS with nasal polyps it's reported between 60 to 80%. So and this divergence between AFS and ABPA is even further. So if there was a link between these two diseases, you would expect that the prevalence would be much higher, and you don't see that.
Perfect. Let's go to the last one, if you don't mind. So this colleague say that PCR was found to be one of the most sensitive method. However, its specificity was lower in comparison to KOH microscopy and culture. Do you agree?
I can at least comment on our experience when we did it. I mean, PCR picks everything. And I think the very important point was Amber said, where do you take your sample? So we did nasal lavages on the nasal cavity, and you had 100% fungi in a certain time of the year. And then when you do that from the sinus, or you take it locally and you don't wash everything, I think it changes a lot. PCR just tells you what's everywhere, and it's not specific. But when you do your pathology or your culture, you specifically go into the area, and if it's found in the sinus, in that way it's more precise. The lavages are more difficult to control. I think there what it comes the difference.
Great. So I think that we're on time, but I would love if you could handle the other question personally, if I can address those questions. First of all, I would like to remind everyone to follow, join, and be updated on the Women in Rhinology activities around. There's a site that you can visit. You can stay up to date. They have their own Instagram pages, Facebook pages. So if anyone is interested, please just go there and stay up to date. I hope that you don't mind that I'm promoting such activities and such membership. This is what I want. And, to raise some awareness for that is, first of all, it was a brilliant communication from yours. Perfectly done, all the faculty members. I really appreciated the interaction. It's not so easy to have multiple speakers one at a time, so we made it great. I really enjoyed that, and there's many people. I had to admit there's so many participants by now on Facebook, and not only female, but many great names in rhinologic field, and I'm proud of that. So thank you. First of all, I would like to thank Dr. Loftus for handling and moderating the meeting. And I would like to thank all of yours for the participation and the brilliant communication. And thank you, Elina, for the introduction on my push-up challenge. I was nominated from Osvaldo Enriquez for that. And then I nominated John Delgado on this. So if anyone would like to raise some awareness for PTSD, it's something that you should join. Thank you for being present, for your communication. So I hope that you don't mind if I'm talking to you namely. Thank you, Patricia. Thank you, Roland. Thank you, Jivianne. Thank you, Stephanie, Elina, Amber, and Sarah, who actually wasn't able to attend the whole meeting. Thank you, and I really hope to see you personally again. Everything is going to be how it's supposed to be. Thank you, and have a great day. Ciao.
Bye. Thank you.
Thank you so much.